Good morning, good afternoon, good evening, everybody. And I would like to welcome you to this joint seminar activity, which is a collaboration between the International Association for Comparative Research on Leukemia and Related Diseases and the International Academy for Clinical Hematology. So basically, the aspect of comparative research on leukemia and related diseases led in 1960 the WHO, the World Health Organization, to inaugurate the International Association for Comparative Research on Leukemia and Related Diseases. And it is face-to-face symposia to take place at various sites around the world every 2 years. The comparative aspects indeed brings together physicians, veterinarians, and scientists in basic research to promote research and to improve outcome in leukemia and related diseases worldwide. And as part of the partnership between the IACRLRD and the International Academy for Clinical Hematology, IACH, we are pleased to invite you to participate to this webinar series, Preclinical and Translational Aspects of Hematological Malignancies, including comparative research from animal models. So this third webinar is taking place today and is entitled Targeted Diagnosis and Therapy of NPM1-mutated AML. The speaker will be Professor Brunangelo Falini from Perugia, Italy. So Professor Falini is a highly cited scientist and published more than 450 papers on PubMed with an H index of 118 and more than 90,000 citations on Google Scholar. He made seminal contributions in the field of leukemia and lymphoma, including generation of novel monoclonal antibodies, again, oncogene products such as PML, NPM1, ALK, BCL6, MUM1, and IRTA1. He also developed the first immunotherapy of refractory relapsed classic Hodgkin lymphoma with anti-CD30 immunotoxin and landmark work on mutational landscape of classical Hodgkin lymphoma. He discovered NPM1 and BCOR mutations in acute myeloid leukemia. He discovered BRAF mutation in hairy cell leukemia and its targeted therapy with BRAF V600E inhibitors. And he pioneered work in the classification of hematological tumors, co-signing the REAL and WHO classification from 2001 to 2022 with identification of distinct genetic entities such as ALK-positive anaplastic large cell lymphoma and NPM1-mutated AML. So these discoveries unraveled new mechanisms of leukemogenesis and led to improved diagnosis, prognostication, and treatment of AML and hairy cell leukemia patients. Because of these landmark contributions, Professor Falini has been recipient of numerous prizes, including the José Carreras Award from the European Hematology Association in 2010, the prestigious Leopold Griffuel Prize in 2014 from the French Association for Cancer Research, the Prize for Excellence in Medicine from the American-Italian Cancer Foundation in 2017, and the Henry Stratton Medal from the American Society of Hematology in 2018. Professor Falini, the floor is yours, and thank you for accepting the invitation.
Thank you, Ali, for the kind introduction. Thank you to the organizers for the kind invitation to take this seminar, whose topic is targeted diagnosis and therapy of NPM1-mutated AML. And I would like to start summarizing the functions of NPM1 nucleophosmin gene that is located on long arm of chromosome 5 and encodes from a protein that is mainly located in the nucleolus and specifically in the so-called granular component of the nucleolus. NPM1 is although is located in the nucleolus, is a nuclear cytoplasmic shuttling protein with multiple functions, including regulation of duplication of centrosome, controlling of ribosomal biogenesis. NPM1 is also involved in the DNA repair and in the nuclear stress response. One question is why wild-type NPM1 that is shuttling between the nucleus and the cytoplasm is localized mostly in the nucleolus by immunohistochemistry, as you can see in these images. The explanation is related to the functional domains that regulates the traffic of native NPM1 in the cells. One of these functional domain is called NLS, or nuclear localization domain, which is responsible for the nuclear localization of the protein. Another functional domain is the so-called nuclear localization domain, which has three helix structures and is responsible for moving the protein from the nucleoplasm to the nucleoli. The third functional domain is the so-called NES, so the nuclear export signal domain, and there are two of these NES in the native NPM1 protein, and this functional domain is responsible for the export of the NPM1 from the nucleoli to the cytoplasm. So in the steady time condition, the import signals in the of the native protein are much stronger, as you can see, than the nuclear export signals due to the NES motif, because the NES motif in the normal native protein is quite weak. So, although the protein is shuttling between the nucleus and the cytoplasm, at the steady time, the more than 99% of the protein will be localized in the nuclei of the cells. In 2005, stemming from our observation in anaplastic large cell lymphoma of the 2-5 translocation, where the NPM1 protein, instead of being localized in the nuclei, is localized in the cytoplasm, we move this observation to other tumors and found that about one-third of acute myeloid leukemia were characterized by abnormal cytoplasmic dislocation of nucleophosmin as compared to the normal residual hemopoietic cells that showed a nucleolar restricted distribution. This abnormal ectopic cytoplasmic dislocation of nucleophosmin in leukemic cells was observed in about 35% of acute myeloid leukemia that were investigated by immunohistochemistry in the setting of the GMEMA trials in the bone marrow biopsies. And there were other two important observations, that cytoplasmic staining was associated in most of the cases, in almost 90% of cases, with a normal cytogenetics. And the second observation was that cytoplasmic NPM1 was mutually exclusive with recurrent genetic abnormalities, such as, for example, the 1517 translocation of APL, or invasion 16, or the 821 translocation. The third observation in that study was that the cytoplasmic NPM1 was associated in about 40% of cases with FLT3 ITD mutations. So this suggested that NPM1, cytoplasmic NPM1, could recognize some kind of different entity as compared to the one that were recognized already. And this prompted us to sequence the NPM1 gene and to discover mutations that were mostly localized at exon 12 of the gene. And these mutations, strikingly, were all causing some changes of at the C-terminus of the NPM1 wild type that were responsible for the cytoplasmic dislocation of this protein. In particular, which are these kind of alteration that were caused by mutations. The first one was a change in the two tryptophans at position 288 and 290, which constitutes the nuclear localization signal that, as you remember, for the native protein is responsible for the binding of this of the wild-type protein to the nucleoli. So these changes in the tryptophan abolish the capability of the mutant to bind to the nucleoli of the cells, of the leukemic cells. At the same time, the mutation insert a new nuclear response signal motif in the NPM1 molecule. So instead of having two NES motifs, as you have in the native protein, you have three NES motifs. So the capability of the mutant to be exported from the nucleoli through the cytoplasm is dramatically increased by binding of this protein of the NES motif to the XP1 or CRM1, which is the so-called exporting protein, which is responsible for the export of NPM1 from the nucleoli to the cytoplasm. So, as compared to the normal situation, you can see that now in the NPM1-mutated leukemic cells, the input signal are much less stronger than the export signal, and the result is that the totality of the NPM1 mutant protein will be exported in the cytoplasm. Since the mutant is able to form heterodimers with the wild-type protein of the unmutated allele, not only the mutant will be exported in the cytoplasm, but through the formation of heterodimers, also at least a percentage of the wild-type protein will be exported in the cytoplasm. Diagnostically, this can be exploited by immunohistochemistry in recognizing of the cytoplasmic NPM1 in tissue biopsies, which is a surrogate for NPM1 mutations. And you have two kinds of antibodies that can be used for these purposes. One is an antibody that recognizes the N-terminus of the NPM1 wild-type protein and also recognize the mutant. So recognize both the wild-type and the mutant. And this antibody will recognize the leukemic cells, cytoplasmic positive in the derma, in this myeloid sarcoma in the skin. And in addition, we recognize also the overlying epidermis, which is being normal, will be labeled only in the nuclear line. Then we have generated a NPM1 a monoclonal antibody specific for the NPM1 mutant A that recognize only the specific mutated portion of the C-terminus. The same antibody, when tested on the same session, will stain, this is immunoperoxidase staining, only in the cytoplasm, the leukemic cells, but will not stain the overlying epidermis because this antibody is tumor specific and will stain in the human body only NPM1 mutated cells. So we have, as you know, NPM1 mutated AML is a distinct entity in the WHO classification and ICC classification. And you can recognize this entity by a number of assays, including immunohistochemistry and molecular methods that can able to recognize NPM1 mutations. So you can recognize NPM1 mutation by molecular assay or by immunohistochemistry, which is a surrogate for NPM1 mutation. These assays are qualitative assay. Then you have also quantitative assay, RT-PCR, by which you can monitor residual disease, minimal residual disease in NPM1 mutated and NPM1. I have summarized here, which according to the WHO classification are the properties of this entity. NPM1 mutated AML represents about 1/3 of all adult AML, is least frequent in children, only 2–8% of AML. It accounts for 56%, 60% of all AML with a normal karyotype. It has female predominance. Is in terms of FAB category, is mostly myelomonocytic or monocytic leukemia, although other FAB categories are represented. About 25% of cases show multilineage dysplasia, and this is explained because sometimes can be misdiagnosed as myelodysplasia. It is characterized by high white blood cell count, especially if other mutations are present, such as FLT3 or RAS mutations. Extramedullary involvement is quite common, especially skin. It is characterized by a distinct gene expression profiling, which is characterized by downregulation of CD34 and upregulation of oxygenes. There is, as I mentioned, no or low expression of CD34 in the tumor biopsy population, although the rare leukemic cells are carrying CD34. CD34 positive leukemic cells carry the NPM1 mutation. It is characterized by excellent response to induction therapy, but suboptimal response to hypomethylating agents. NPM1 mutated without FLT3-ITD mutation is characterized by good prognosis, such as, for example, cases commutated for NPM1 and NRAS, or commutated for NPM1 RAD21. Instead, conversely, cases which are commutated for NPM1 and FLT3-ITD or NPM1-T1, or triple mutated for NPM1, FLT3-ITD, and DMT3 are characterized by a particularly poor prognosis. So there are, however, still controversial issues in the classification, and I will now address some of these issues. First of all, which is the blast percentage requires to diagnose an NPM1 mutated AML? In the WHO 16 classification, the percentage of blast required for diagnosis of NPM1 mutated AML was established to be higher or equal to 20%. Now, as you know, we have two different classifications: the International Consensus Conference classification and the 5th edition of the WHO classification. In the IACH classification, you can diagnose NPM1-mutated AML when you have a percentage of blasts which is higher or equal to 10%, whilst the WHO 5th edition does not require any cutoff, blast cutoff for diagnosis of ML. So it's independent by the percentage of the blast. In order to address this issue, you must compare, we compared NPM1-mutated AML, typical de novo AML, with NPM1-mutated myeloplasm with less than 10% of blast, that is cases defined as NPM1-mutated MDS or MDS-NPM. And then we compare these two categories with typical myelodysplasia with wild type NPM1. And what we found is that NPM1-mutated MDS or MDS-NPM resemble much more to typical NPM1-mutated AML than to myelodysplasia with wild type NPM1 in terms of CD34 expression, which are negative in both NPM1-mutated MDS and NPM1-mutated AML, karyotype that are both normal in these two situations, while they're usually abnormal in MDS with wild type NPM1. In terms of expression of myelodysplasia related mutation, which are rare in both NPM1-mutated MDS and NPM1-mutated AML, are really and are frequent in myelodysplasia with wild type NPM1. And in terms also of response to hypomethylating agent, which is scarce in these two situations, whilst it's good in myelodysplasia with wild type NPM1. And another issue that you must consider, there are now studies that show there are no difference in terms of overall survival in NPM1-mutated myeloid neoplasm that have less than 10% of blast and more than 10% of blast in terms of response to intensive chemotherapy. So all these issues suggest that NPM1 mutated myeloid leukemia can be defined as such independently by the percentage of the blast. Even with a low percentage of blast, less than 10% of blast, 5% of blast, we believe that these cases should consider as AML and treated accordingly. And using the NPM1, the monoclonal antibody specific for the mutant, you can pick up in this MDS myeloid mutated neoplasm rare clusters of cytoplasmic positive cells, including proerythroblast, And however, in this situation, you can recognizing that the amount of blast defined by immunohistochemistry is even higher than the one that you can define by morphology alone. And this support the concept that these cases are really AML. So another issue that I would like to address, which is poorly known, is the detection of NPM1 mutations with NPM mutation occurring in exon other than 12. That usually the exon that is involved in this leukemia. So how we recognize this mutant? Through we came up with cases of leukemia that were characterized by cytoplasmic dislocation of nucleophosmin, but that at molecular assay were showed no NPM1 mutation at exon 12. We investigated these cases by Western blotting and found that these are characterized by expression of the wild type NPM1 when staining by the appropriate antibodies. And when we characterize further these cases, we found by sequencing, we found that these cases are mutated at exon, were mutated at exon 5 and were characterized by a C-terminus sequence, which is identical to the C-terminus sequence of the native NPM1 protein. And this is a curious findings because of all the other mutants occurring at exon 12 have a different C-terminus sequence as compared to the native protein. In addition, as occurs in the other NPM1 mutants, there is the insertion of a new NES motif, even in the cases in which the mutation occurs at exon 5. And when these constructs were investigated, we found that as the mutants occurring at exon 12, even the mutants involving exon 5 were characterized by the capability to be expressed in the cytoplasm of the leukemic cells. So I have summarized here which are the characteristics of the mutation occurring at exon 5. All the mutations so far identified are different. The C-terminus sequence is unique and identical to that of the NPM1 wild type. There is the presence of a NES motif, which is particularly strong because it has to overcome the capability of the mutant to bind the nucleoli. And this mutant can be detected by the antibody directed against the N-terminus of the protein, but not against the antibody against the mutant A, because the sequence is different from this mutant occurring at exon 5. And these mutant have the same gene expression profiling, that is upregulation of oxygen, as the mutant that has the mutations that occurs at exon 12. And you can recognize this by utilizing in combination immunohistochemistry with the DNA fragment analysis. And when you have discrepancy, that is cytoplasmic NPM1 with a negative DNA fragment analysis that exploring only exon 12, then you have this an indication that you have to sequence all the other exon NPM1, and in that situation you can find mutation at exon 5, as I explained you, but there have been also described mutation at exon 9 and 11. If you have negative if the sequencing from the other exon of NPM1 is negative, then you have to perform RNA-seq, because the cytoplasmic dislocation may be due to NPM1 containing fusion proteins that can give you the same immunohistochemical pattern. Alternative, you recognize this mutation at exon 5, 9, or 11 using NGS targeted sequencing, but you must include in the analysis these exons, because usually in this analysis only exon 12 is included. A third question is concerning NPM1 mutation and therapy-related NPM1. We have, as you know, therapy-related AML is a category in the WHO 2016 classification. Now, therapy-related is used as a qualifier in the ICC classification. Therapy-related AML can be due either to chromosomal translocations or deletion or monosomy or complex karyotype, and may also due to mutation that usually occur to the TP53 or PPMD1. When you look at therapy-related AML, you find that about 10% of these cases carry NPM1 mutation. And these cases are curiously characterized, unlike other therapy-related AML, by a normal karyotype. And indeed, when you look at, we have looked through almost 3,000 cases of AML, mostly with NPM1 mutation, comparing these cases, de novo AML NPM1 mutated with therapy-related, with 100 therapy-related NPM1, almost 400 cases of therapy-related AML with NPM1 wild type, and we found that NPM1-mutated de novo AML and therapy-related NPM1-mutated AML, they resemble much more each another in terms of number of platelets, which are higher as compared to therapy-related AML with wild-type AML, in terms of karyotype, which is usually normal in this condition as compared to therapy-related AML with wild-type AML, and in terms of karyotypic abnormalities, which are conversely less frequent in NPM1 therapy-related AML and de novo AML as compared with these other conditions. So, and FLT3-ITD mutation, which are frequent in de novo and therapy-related NPM1 mutated AML, but very, very rare in the therapy-related AML with normal type, with wild type NPM1. And when we looked also at the mutation, we found that the frequency of DMT3 and TET2 mutation is much more similar in de novo and therapy-related NPM1 mutated AML, wise is much less frequent in therapy-related AML with NPM1 wild type. Moreover, when looking at RNA sequencing, you have that this, looking at this with this technique, there are clearly overlapping features of de novo and therapy-related NPM1 mutated AML as compared to therapy-related AML with wild-type NPM1. And when you're looking at the outcome, you see that therapy-related and de novo NPM1 mutated AML are more or less the same overall survival and relapse-free survival, which is with an outcome which is better than therapy-related AML with wild-type NPM1. And the same applies also to the NPM1 mutated AML therapy-related and de novo belonging to the ELN favorable risk, that is FLT3 ITD negative. So what we can conclude is that therapy-related NPM1 mutated AML is not distinguishable by de novo NPM mutated AML, and as such, it should be considered a de novo leukemia. In which there is an history of previous chemotherapy and radiotherapy, but that this history has no impact in the pathogenesis, on the molecular pathogenesis of this leukemia. So in this algorithm, if you have an AML and you have an history of previous chemotherapy or radiotherapy, and if you have a mutated NPM1, then if you have that, you should classify this not as a therapy-related NPM mutated AML, but NPM mutated AML de novo. This leukemia should be treated with TRAS plus 7 plus gentuximab. And instead, if you have no mutated AML1, NPM1, the cases should be considered as a therapy-related AML and should be treated with GPX351. Then I would like to go to the importance of MRD guided therapy in NPM1-mutated AML. And first of all, I would like to address that the NPM1 evaluation of the NPM1 status is an important step in the ELN prognostication of NPM-mutated AML, because NPM1 mutated without FLT3-ITD defines a category with a good risk, while NPM1 mutated NPM1 with FLT3-ITD define any intermediate risk category for which the allogeneic stem cell transplantation should be considered. Whilst for cases with a favorable risk, NPM1 mutated without FLT3-ITD, the study from Schlenk colleagues demonstrated that there is no impact, no favorable impact of an allotransplant in this setting. However, NPM1 mutated may be co-mutated with a number of patterns which are here summarized other than FLT3. So it is very difficult to define the prognostic risk of all these combination of commutation. So the question is whether we can use evaluation of MRD, minimal residual disease, to establish outcome in acute myeloid leukemia. And here I refer to the study from MRC that was led by David Greenwood, in which it was established in multivariate analysis MRD status after cycle 2 of chemotherapy remained the only independent prognostic factor in acute myeloid leukemia with NPM1 mutation. In particular, the MRD negativity is associated with a better survival than cases of MRD positive, and with a lower incidence of lower cumulative incidence of relapse in cases which are MRD negative. But this evaluation of MRD negativity can be also combined with the genetic stratification. For example, in cases of patients without FLT3-ITD mutation with good risk to find MRD positivity, place the cases in high risk setting. And conversely, in patients with FLT3-ITD mutation, to discover MRD negativity places these cases in a in a setting with low risk. So we can combine genetic risk stratification and MRD evaluation to further refine stratification, genetic stratification of NPM1-mutated AML patient. And this is true not only for cases for which we have used the chemotherapy, but also for cases in which that have been treated with venetoclax-based regimens in which to be MRD negativity after the end of cycle 4 is associated with better overall survival and event-free survival and lower cumulative incidence of relapse as compared with the cases which are MRD positive. And MRD evaluation has been also assessed to evaluate cases of acute myeloid leukemia treated with venetoclax-based regimens at molecular labs. So in these cases, after using venetoclax combination for molecular failure, that is for increase of the molecular transcripts after achieving a complete molecular remission, was associated with MRD negativity in almost 71% of the cases and in excellent overall survival. So the message that now in cases of patients with NPM1-mutated AML who experience molecular relapse, we can use venetoclax-based regimen to achieve complete molecular remission that can serve, can be used as bridge to allogeneic transplant in most of these cases. And also, we can use evaluation of MRD as a guide to decide whether to perform or not an allogeneic transplant, because achieving MRD negativity in the blood after second induction chemotherapy showed no survival benefit from transplant in first remission, even in cases with FLTD mutations. And now there is the striking also opportunity to use the monoclonal antibody specific for the NPM1 mutant, which does not stain normal tissues, normal cells, to pick up rare NPM cytoplasmic cells, as you can see here, to investigate by minimal residual disease, even by immunohistochemistry. Now I will conclude my presentation addressing two issues regarding targeted therapy with menin inhibitors and XP1 inhibitors. First of all, I would like to highlight that NPM1-mutated, the current standard for NPM1-mutated AML for fit patient is intensive chemotherapy plus gentuximab, oxamicin. While for unfit patient is venetoclax plus hypomethylating agents or low-dose cytosine arabinoside. But we have also other opportunity because many inhibitors are known to interfere with the interaction of menin with KM22A for NPM1-mutated AML, or KM22A fusion protein for KM22A rearranged protein, and that this interference of menin inhibitors cause downregulation of OX gene expression and induction of the differentiation in NPM1-mutated AML or KM22A rearranged leukemia. And we know that administration of menin inhibitors in knock-in model of NPM1-mutated FLT3-ITD leukemia results in eradication of the leukemia in these mice. And we have now also information about the response to treatment of revumenib, which is a specific inhibitor of menin in NPM1-mutated AML, where we have about 36% overall response with 21% of complete hematological response in NPM1-mutated AML, interestingly with high rate of MRD negativity and with a number of adverse events that, however, most of them are tolerable, including differentiation syndrome in about 16% of cases, and prolonged QT in about half of the cases. And one problem that is emerging with the therapy with menin inhibitors is the occurrence of menin mutations that developed after 1 or 2 cycles in up to 38% of patients, and these mutations map usually to the KM2A binding pocket of the molecule. We have other interesting inhibitors of menin in addition to revumenib. For example, ziftomenib, that is associated with a higher percentage of complete remission, 35 versus 21%, and with a lower incidence of differentiation syndrome, and with no reports of QTc prolongation. That may represent an advantage of this agent in NPM1-mutated AML. And of course, the results of these menin inhibitors as single agent may be proved using menin inhibitors in combination with intensive chemotherapy, either as a frontline therapy or in the refractory relapse setting, or using menin inhibitors in combination with venetoclax-based regimens, either in frontline setting or in the refractory relapsed AML. As, for example, in these phase 1 studies in which revumenib has been used in combination with venetoclax plus azacitidine in newly diagnosed older adult patients with NPM1-mutated AML in the context of the BEAT-AML trial, with really remarkable 100% complete response rate and measurable disease negativity in 86 to 100% of cases. Now I would like to address the XP1 inhibitors issue. As I mentioned previously, there are two alterations induced by the mutational C-terminus of the NPM1 wild type. One is the mutation to tryptophan, but the other one is the insertion of a new NES motif in green in all mutants. So it was interesting to explore with my colleague Lorenzo Brunetti the significance of a NES motif in the context of the NPM1-mutated OCML3 cell line. In particular, Dr. Brunetti removed the NES from the mutant allele of this cell line by Cas9 technology. And so this caused, of course, relocalization of the protein of the mutant from the cytoplasm to the nucleus. And then he investigated which was the effect of this nuclear localization in terms of biological function. What it was observed cell growth of rest, and these cells also in which the mutant was relocated to the nucleus differentiate more and showed a downregulation of oxygen. Instead of gene editing, you can, of course, cause a relocalization of the mutant from the cytoplasm to the nuclei, to the nuclei, using XP1 inhibitor, that is such as selinexor or deltanexor or ratiadone or leptomycin. And this selinexor and deltanexor inhibits the nuclear export of the NPM1, and then so they cause the cytoplasmic relocalization of the mutant. And in addition to acting to the nuclear transport of NPM, it's important to remember that these XP1 inhibitors also interacts with the XP1 which is linked to the chromatin, and they cause disengagement of the NPM1 mutant from DNA, disrupting the XP1 NPM1 C1 complex in the chromatin. So these XP1 inhibitors acts not only on the traffic, inhibiting the traffic on nucleophosmin, but also on the binding of the mutant with the XP1, which is bind to the chromatin. Independently by whether the effect on the relocalization of the mutant from the cytoplasm to the nucleoli, or the effect is chromatin localized, the effect on these cells is exactly the same than the gene editing, that is cell growth arrest, differentiation, and OX gene downregulation. So we are at this moment exploring the effect of eltanexor in NPM1-mutated AML as compared to selinexor, because eltanexor has a lower toxicity profile, minimal penetration of the blood-brain barrier, and it can be administered continuously 5 days a week. And in this way, it is possible to obtain with eltanexor continuous XP1 inhibition. And now we know, both in vitro and in vivo, that continuous XPV inhibition is critical to achieve efficient differentiation of the leukemic cells and in increase survival of the mice as compared to the selinexor or XP1 inhibition that is causing only an intermittent XP1 inhibition. So now we are running an ELINA phase 1/2 pilot study with eltanexor in relapsed refractory NPM1-mutated AML. Is an academic trial, and we are enrolling patients in this study. The hope is that we can demonstrate in this study is that as compared to previous phase 1 study in which selinexor was not efficient in NPM1-mutated AML, we can demonstrate activity because of the continuous activity of an eltanexor on XP1 inhibition. And this, I will conclude just thanking all the people who cooperated with these studies and the organization IACRLRD and IRC that supported this study. Thank you very much for your attention.
Thank you very much, Professor Falini, for a fantastic presentation from the bench to the bedside. We are quite late, so I will just take the 3 questions from the chat. The first one is by Hassan Yassin. If therapy-related AML, which is NPM1 mutated, is a de novo AML, why not to use venetoclax-based high-intensity chemo instead of gemtuzumab?
Yes, of course, I fully agree. You can use in unfit patient venetoclax-based regimens. I mentioned just the 3+7 plus gentuximab regimen because I was referring to fit patient. But for unfit patient, I would fully agree that venetoclax-based regimen would be okay.
The second question is by Dr. Jean Sheikh. Any role of venetoclax monotherapy for molecular relapse of NPM1 post-allo transplant despite GVHD?
Yes, I think that there is a role for molecular relapse after transplant with venetoclax-based regimens. I'm not aware of many studies that have investigated this issue, but I think that this is a setting where really this combination should be investigated.
So another question by Baldi Pujar, 64-year-old AML, NPM1 and CR/MRD negative after induction chemo. Would you do allogeneic stem cell transplant based on age above 60?
Age over
60, so 64,
64, okay.
AML, NPM1, CR/MRD negative.
Yes, I would not certainly perform an allogenic transplant in this kind of patient if you have MRD negativity after the 2 cycles of chemotherapy, even though this patient is FLT3-ITD positive.
So another question by Julia Furnari. So type A, B, and C NPM1 mutation are all on exon 12. What do you think in the future of MRD monitoring for the today non-quantifiable NPM1 mutations?
I think that you can design anyway primers to quantify even rare mutations in this setting of patients. Another possibility, although we don't have yet comparison data between molecular techniques and immunohistochemistry, is to use immunohistochemistry with the monoclonal antibody direct against the mutant that is which is recognizing a mutation A, B, and C, and that it can be used in bone marrow biopsies.
Okay, so I think we are quite late. So I'm sorry there are more questions, but it's already 8:13 p.m. in Beirut, 7:13 in Perugia. So I would like to thank again Professor Brunangelo Falini for an outstanding presentation, to thank the IACH platform for hosting this joint IACRLRD and IACH seminar, and to thank you all for your attention and your presence. Have a nice evening, and see you soon after the vacations. Bye.
Bye-bye. Bye-bye.